our first ChilD webinar for 2026. We are thrilled to kick off our first webinar recognizing Epilepsy Awareness Month, which is February. And it is my great pleasure to introduce our guest speaker for this evening, Mr. Janome Montaqu, who is a counselling social worker from Epilepsy South Africa. And he also specializes in psychosocial support, advocacy, and epilepsy education. So Janome has joined us. He has had some challenges with his connectivity, so we apologize for the slight delay in starting tonight. But Janome has also, unfortunately, not going to be able to share his camera with us, but he is with us and he is going to be giving us an overview of epilepsy. And then we're also going to be chatting at the end of Janome's presentation to Taryn Zoe Gur, who is an individual with lived experience of epilepsy. And we will then open it up for questions, discussion. There have been quite a few participants that have sent through their questions in advance. So we hope that we can address these as we continue through this evening. So on behalf of ChilD, a very big welcome to you, Janome. Thank you for being with us tonight. So if you are able to share your screen, then we can begin. Great, we can see it. Okay, Janome, you're still muted. Okay. Janome?
Apologies for that. I think I'm all sorted now.
Okay, all right, excellent.
So good evening all. I apologize for the delay in start. Thank you also to my colleague that have introduced me already. Like she said, I am Janome Montaqu. I am a social worker committed to education and awareness around epilepsy and also other neurological conditions. I work with families, I work with schools, I also work with communities to reduce the stigma around epilepsy. I also provide training and ensure that people living with epilepsy are supported to live full and dignified lives. So today, I'll be guiding you through an awareness session on epilepsy. Number one, what it is, the different types of seizures, the common myths and the misconceptions, also the first aid responses, some lifestyle tips, and also the rights of people with disability in South Africa. And in this context, it will be epilepsy. I hope I'm clear. I hope I'm loud enough for everyone to hear.
The sound is good. Thanks, Janome.
So let us proceed. Just a brief background of our organization. So South Africa, Epilepsy South Africa was founded in 1967 under the name of SANEL. SANEL was short for South African National Epilepsy Week. However, in the year 2002, I think it was in the month of April, that our organization underwent a name change to Epilepsy South Africa. As it is today, Epilepsy South Africa remains the only known organization in South Africa that offers specialized services to those living with epilepsy and also other neurological conditions. Our aim basically is to improve the quality of life for all our target groups. So basically our services, it entails counseling, epilepsy training and awareness, protective employment, accredited learnership programs for people, young people rather, between the ages of 18 and 28, depending that they do have epilepsy or any other neurological conditions. And we also provide support groups whenever there is a need for such. So we have six branches nationally. These branches are located in the Eastern Cape, the Free State, Northwest, Gauteng, Mpumalanga, Limpopo, South Cape Karoo, which is basically in the Western Cape, and also the Western Cape branch, which is situated in Cape Town. I am from the Western Cape branch. So I want to start with the very definition of epilepsy. What is epilepsy? Before I proceed, is there maybe anyone that wants to, I'm not sure, wants to give thought or wants to provide an answer to that question very briefly? If not, I will proceed. So what is epilepsy? Epilepsy is one of the most common neurological conditions. How we define epilepsy, we define it as a condition that is characterized by repeated seizures. Another way to term epilepsy is a condition where the brain's electrical system misfires, and this leads to repeated seizures. So a person needs to undergo 2 unprovoked seizures before a medical doctor or a neurologist can successfully diagnose it as epilepsy. So epilepsy happens as a result of abnormal electrical activity of the brain, also known as seizures, basically. So you can think of it as a temporary power surge in the brain that interrupts normal functioning. So I have touched on seizures. Somebody might ask, what is a seizure? In order to define a seizure, you need to know that you do have a brain, and the brain consists of a vast network of nerve cells that are known as neurons. So these neurons are responsible for everything that we do, from thinking to talking to walking to reading, eating, basically everything. And whenever there is a temporary change in the way that the brain cells work, or whenever there's a sudden disruption in the brain's normal electrical activity, the person goes into a seizure. Causes of epilepsy. There are basically, as it pertains to causes, there are basically 2 different categories of epilepsy. Number 1, you have your idiopathic epilepsy. Idiopathic epilepsy is an epilepsy type without a clear cause. In most cases, the doctors or the neurologists cannot determine the underlying cause for the epilepsy. In most epilepsy cases falls under this category. Over 50 to 70% of epilepsy cases, the causes are widely unknown, basically. Then you have your symptomatic epilepsy. Your symptomatic epilepsy is an epilepsy type that are directly linked to a brain injury or a condition. Some of the causes includes, number 1, head injury, or a medical professional will maybe call it head trauma. And this is damage that stems from either a car accident, maybe a sport injury, maybe fall. Somebody can have the unfortunate event of ascending a ladder and then fall from that very same ladder, and that can bring injury to the head or the brain area. Another cause basically can be your cerebral hemorrhage, and this is known as bleeding of the brain or bleeding in the brain. It often results from a stroke or any other injury that occurs around that area. Another cause can be brain infections. Brain infections will be your inflammation, or as the everyday person will call it, swelling of the brain or the surrounding tissue of the brain. And this can lead basically to your meningitis and your encephalitis. And these are basically caused by bacteria or other viruses. Another cause can be tumors, which are very cancerous in nature. We know that a tumor is also a lump, basically. It is when there's a cell that grows abnormally within the brain, and that interferes with the normal activity, electrical activity of the brain. Then another cause can be your biochemical imbalances. Remember, your biochemical imbalances are the brain's natural chemicals, and these natural chemicals, it regulates your mood, it regulates your emotions, it regulates your focus, and also your sleep. And whenever you have either too little or too many of these chemicals within the brain area, it can also lead to seizures, basically. Then you have degeneration. Degeneration is just an advanced term, basically, for age-related changes in the brain that make seizures more likely or provocable. Then you have drugs and alcohol. We know that drugs and alcohol are substances, and whenever you make use of a certain substance, that substance can damage your brain cells. It can interfere with medication and also lower the seizure threshold, basically. Just some facts about epilepsy. Epilepsy can affect anyone at any given stage of their life. I normally tell people that epilepsy is a non-discriminative condition, meaning that it can develop in anyone, irrespective of your age, irrespective of your gender, irrespective of your race, your educational, your cultural, or your economic background. Fact number 2, about 1 in every 100 people has epilepsy. And also epilepsy is the most common neurological condition. Another fact is that there are approximately 50 million people worldwide that are living currently with epilepsy. Let us look at the different types of seizures. So you do have different types of seizures. You also have, again, 2 main categories of seizures. Number 1, you have your generalized seizures. So remember I said a seizure occurs whenever there is a sudden disruption or a temporary change in the way that your brain cells work, or whenever your signals basically spirals out of control. Your electrical signal spirals out of control. And whenever such happens, basically within the brain organ, it almost looks like an electrical storm that is taking place in the brain area. And that means the seizure encompasses the entire brain organ. And whenever that happens, we call it generalized seizures. So let us look at generalized seizures firstly. There are different types of generalized seizures. Number 1, you have your absent seizures. So your absent seizures were formerly rather known as your petit mal seizures. Hence, however, we discourage people from using that specific phrase because we believe it is extremely derogatory in nature, because it basically implies that the person is abnormal. And we at Epilepsy South Africa refrain from that thought, and we do not believe that anything is mentally wrong with the person. We believe it is a condition basically of the brain, or a neurological condition, as I've mentioned. Absent seizures basically are short episodes. It's very prevalent in children. It is characterized by a blank stare and a failure to respond. Like I said, it's extremely short. We normally expect it to last for 30 seconds. The good thing about this seizure is that it normally ceases to exist once the child reaches adulthood, and it's also fairly easy to control once you do take your prescribed medication. However, just because it is prevalent in children does not mean that it cannot be present in adults. There are some adults that undergoes absent seizure activity as well. Let us touch on the second type of generalized seizure, which is your generalized tonic-clonic seizures. Basically, this is a very standard seizure, a seizure that most people are familiar with. They were formerly known as your grand mal seizures. Again, we at Epilepsy South Africa believe that people should refrain from using that specific phrase because for the same reason, we believe it is derogatory in nature, also implying that something is wrong with the person's brain, basically. The person is abnormal. So this specific seizure have two stages. Stage number one, you have the tonic stage. Remember tonic, it means stiff. So you have the tonic stage. And during this stage or this phase, the body stiffens, the person may fall to the ground, and the person may also give a shout as air is being forced from their lungs. The person then migrates into the second phase, and that is known as the tonic phase. So the tonic phase is characterized by convulsions. Basically, the person shakes uncontrollably. The person may also turn blue around their mouth area due to a lack of oxygen. The person may wet himself or herself. The person may also make strange noises, and the person's consciousness may also be lost for a few minutes. Normally, we expect this specific seizure also last for a few minutes, 3 minutes at max, but it can be longer, but I will go into that a little bit later. Then you have your myoclonic seizures. These are your sudden jerks of muscles, like when your arm or your leg jumps unexpectedly, basically. And the person may also fall as a result of that. Your tonic seizures, like I've said, tonic means stiff. This is where the body stiffens. The person may fall to the ground, and the person may also shout as a result. Then lastly, under your generalized seizures, do you have your atonic seizures, also known as your drop seizures or your drop attacks. It is a sudden loss of muscle tone, basically. The person goes limp and drops to the ground and may drop to the ground as a result. Sometimes the person themselves may not fall to the ground or drop to the ground, but they may drop whatever is in their hands. Then you have your partial seizures. Medical professionals will call or refer to your partial seizures also as your focal seizures. Remember when I said that during a seizure, it's almost like an electrical storm that have erupted within the brain organ of the person undergoing the seizure activity. So that electrical storm only occurs in a localized area of the brain. It's only limited to one area of the brain. Remember, your brain have various areas or various compartments, and they are responsible basically for different things. And during a partial seizure, it only means that one specific area is affected by the seizure activity. So under your partial seizure, do you have your simple partial seizure? Your consciousness is not lost or affected basically during the seizure, but the person may feel strange, a tingling feeling. They may feel numb, or they may even jerk in one limb as well. Then you have your complex partial seizures, also commonly known as your focal impaired awareness seizures. It originates in the temporal lobe of the brain. The temporal lobe is responsible for visualization and also memory, amongst other things. It is a non-convulsive seizure, meaning that there are no shakings involved. It also may start with an aura, and this aura may be visual, auditory, or in your taste, or in your smell, etc. During this seizure, the person may display abnormal behavior or movements, such as plucking their clothes, smacking their lips. They may lose their sense of time. They may become disorientated, or they might even wander around aimlessly. So we always encourage people, whenever somebody is maybe appearing to be sleepwalking, and it often happens, you are maybe talking to the person and there's no response as well. Sometimes, if it is happening quite frequently, we encourage people to take or to talk to the person, to consult a medical doctor or a neurologist, because it might be a sign of epilepsy. As I've said, that your consciousness is not lost during your focal seizures or your partial seizures, but it can be impaired, or it can be affected to a certain extent. So we also expect the seizure to last only for a few minutes, and with your focal impaired awareness seizures or your complex partial seizures, people often mistaken this for a psychiatric or a psychotic episode, of which it is not. Basically, it is part of a seizure. And remember, I said that a seizure is a neurological condition. It's a condition of the brain. Yeah. Then you have your secondary generalized seizures. In some cases, partial seizures may develop into generalized seizures. What this means, remember I said with a partial seizure or focal seizure, it only occurs in a limited area of the brain, but it might spread, and it might encompasses the entire brain organ. And whenever this happens, basically, we call it secondary generalized seizures, because it is generally spread all over the brain organ. Now, a group discussion. I'm not sure if there is anybody that wants to share some of the common myths or misconceptions, or how they think one should respond to a seizure activity.
I'm not seeing any hands,
Anyone?
but if there are any participants who'd like to unmute or post something in the chat, you are very welcome to.
Yes, good evening.
Good evening.
My name is Alfreda, and my dad has epilepsy. He is turning 80 this year, and he also has Alzheimer's. So one of the things that I've learned, and I know now that it was not the right thing to do, was to take a spoon to remove his dentures whenever he has an episode where he has a seizure. We had to do this when I was a child. My mother would tell us to get the spoon, and she would use the spoon to take out his dentures so that he don't bite his tongue. So what do you do in a case like that, where the person have dentures, or maybe he has his own permanent teeth? What do you do to prevent the person from biting his tongue?
Noted. Anyone else?
Janome, there is a hand from Fiona. I don't know if you want to answer Alfreda first, or get both questions from Fiona as well.
No, let us take both questions, so all questions before
Okay,
I
so Fiona,
answer.
if you want to
Yeah.
unmute.
I am, thank you. It's not really a question, it's a misconception that you have to be afraid of someone who has epilepsy. And the other one is, yeah, exactly the thing about the spoon. You don't put anything between their teeth, as far as I understand. You turn them on their side and make them, safe, and time how long it lasts, and then call for help if you need to.
Thank you for that. Anyone else?
think it's just those two
If there's no one
questions at the
else,
moment.
you're saying?
It's just
I
those
beg
two
your-
questions at the moment.
So we can proceed then. So before I answer, I just want to go through some of the myths and misconceptions about epilepsy. One of the myths is that seizures are always medical emergencies and you should call for an ambulance right away. You don't do this. I will elaborate on this a little bit later. Another myth is that there is only one type of seizure, which is convulsions or uncontrollable shakings. Another myth is that you can cause a seizure to stop by lighting up a flame by the person's face during a seizure. Also, I think with this specific point, like some of the participants have mentioned, some people believe you can put a spoon in the person's mouth. Some people believe that you can take a shoe and hold it on the person's mouth. Some people believe that you can take a wet cloth and you can also use it to wipe the saliva that stems from the person's mouth area. Another common myth is that epilepsy is a form of spiritual possession. Like I've said, we at Epilepsy South Africa believe it is not a form of spiritual possession, but we believe it is a neurological condition characterized by repeated seizures. Another myth is that epilepsy is contagious. Some people believe that once you touch a person that is prone to seizure activities or the person undergoing a seizure activity, that specific seizure activity can also start to affect you and you can develop epilepsy. And there is a myth. Another myth is that epilepsy affects intelligence. That is also not true. Another myth is that epilepsy is severe and people often have frequent seizures. Some people can become seizure-free. We know of people who are living with epilepsy for 50 years right now, and they've been seizure-free for 40 years, basically. What I forgot to mention at the start is that epilepsy is a non-curable condition. However, it is a manageable condition, basically. And we will go into some management tips a little bit later on. Another myth is that during a seizure, you can swallow your tongue. We encourage people to move away from that thought. That you can swallow your tongue. It's not true. It has been medically proven that it is impossible for somebody to swallow their tongue during a seizure activity. So I want to touch on the last point. During a seizure, you can swallow your tongue because a lot of people tend to put their fingers in the person's mouth, and they do so because they want to prevent the person from swallowing their tongue. I also want to touch on the third point, which states that you can cause a seizure to stop by lighting up a flame near the person's face. And as I've also added that some people believe that you can take a spoon, more preferably a wooden spoon, and also a shoe and hold it on the person's mouth area. This can become extremely dangerous. And in your attempt to want to help the person undergoing the seizure activity, you can actually cause more harm than any good, because there are two realities at play. During a seizure, the person's airwaves might be clogged with excess saliva. And that excess saliva can actually make it very difficult for them to breathe smoothly or effectively. So what happens is once you place anything in the person's mouth, it basically interferes with their breathing endeavors. So you are actually making it more difficult for them to breathe. Also, once you place your fingers in the person's mouth, the strength of your jaws can basically injure your fingers. It can actually break your finger bones, and that is something that we do not want. So we discourage people from placing anything in the person's mouth. Sometimes a situation occurs where the person has dentures or false teeth, as we normally call it. Once that is the case, if it is possible for you to remove it at the very start, at the very first few seconds of the seizure, and if it's possible for you to do it, easy for you to do it, then you can. But in general, we actually discourage people from putting anything in the person's mouth, even if it's a piece of bread, even if it's medication. Nothing goes into the mouth area of the person. And as I've already said, that it's impossible for the person to swallow their tongue during a seizure activity. I will tell you later how do we handle basically the fear of somebody swallowing their tongue during a seizure activity. But for now, let us continue. So let us look at some of the triggers. There are some people with epilepsy that are sensitive to certain situations which may trigger a seizure, while there are other people with epilepsy that do not have specific triggers as it pertains to a seizure activity. Possible triggers, basically, it includes forgotten or incorrect medication. Missing your medication is one of the biggest risks, because consistency is sensitive, consistency is extremely vital. Let me put it like that. It's extremely vital. Remember, I spoke of this threshold, basically the seizure threshold, and the brain basically having an electrical activity. There's a certain way in the way that your brain cells work, in the way that your brain cells flow. And sometimes the medical professional can put you on prescribed medication. Your brain then grows accustomed to that routine and accustomed to that medication, basically. And whenever you forget to drink your medication, you can basically trigger a seizure activity. Also, it can be because of fever that you can develop a seizure activity, because fever has to do with heat and or humidity, basically. Remember, again, there's a certain way that your brain cells work. There's a certain flow that it enjoys. Your brain is actually very organized, and it loves organization, your brain cells, basically. And whenever there's a disruption, as I've mentioned, your brain cells can spiral out of control, and that causes you to have the seizure. And one of the contributors to that can be heat or fever, because we know with fever, there is rapid bodily temperature at play. Also, it can be because of lack of sleep. Lack of sleep is also a common trigger, because staying up late or working at night makes the brain more vulnerable. I know a lot of brain scientists will inform us that sleep helps to relax the brain. And I think if we do not sleep, the exact opposite happens. It basically overstimulates the brain's electrical activity. And whenever such a disturbance or such a change takes place, the person can go into a seizure. It can also be because of stress and excitement. Remember, emotional stress like exam pressure, for instance, or any other form of physical stress can basically overstimulate the brain. And the same goes for excitement. Maybe you are excited because of graduation or wedding, whatsoever. That can also basically interferes with the brain's electrical activity, and you can go into a seizure activity. Also, let us go to menstruation. During menstruation, certain hormones are released, normally your estrogen and your progesterone that are released in our females, and that basically can overstimulate the brain and the person can go into a seizure as well. Then photosensitivity. Photosensitivity basically means the person sensitive to light. Strobe lights at clubs or concerts can trigger seizures in people that are sensitive to light, as I've mentioned. Also, a startled response, the person suddenly goes into a frightened stage, and that basically can interrupt the flow of the brain cells known as the neurons. And I said whenever that happens, the person can go into a seizure activity. Also, illness and boredom basically tied, because these are basically indirect triggers to seizures. And what do I mean by that? Once you are bored or once you are ill, you tend to sleep a little bit longer. And once you sleep a little bit longer, you may miss the time that you are supposed to take your prescribed medication. And whenever that reality is at play, remember I said forgotten or incorrect medication can cause a seizure activity or can trigger a seizure activity. I've already touched on hormones, heat, and also alcohol and drugs. I said that if you are drinking at a braai or using any recreational drugs, that can basically interfere with medication or your brain's normal electrical activity. So how can you help? So this basically goes back to the discussion that we had about myths and misconceptions. So what can you do to help a person that is undergoing a seizure activity? Number one, it is important for you to remain calm. I think one of the participants here tonight or the listeners here tonight pointed it out, and that is extremely accurate, and is basically the first most important thing that you do. So you want to remain calm, because if you are not calm, nothing else around you can be calm. You yourself cannot be in control. And if you are not in control, you will not know how to effectively respond to the person who is undergoing the seizure activity. Secondly, you want to look at the time and clock the time basically in your head. There is a very important factor, the time factor. I will elaborate on that in a few minutes or a few minutes here. Then you will want to sorry, Jacqui.
No, sorry, Janome. I think someone just unmuted. You can continue.
Okay. Thirdly, you will want to remove the person's mask. Some people still wear masks, even post-COVID-19, the post-COVID-19 period. Some people may have flu or any other condition and feel the need to wear a mask. So whenever that happens, you gently remove the mask from the person. If it is doable, that basically ties in with you lose also any tight clothing, like if they are buttoned all the way to the top, you only remove the first two buttons so that they can breathe more smoothly, more effectively. Also, if they are having neckwear on, like a scarf or a tie, that you will also want to remove if you are in a position to do so. Then you will want to cushion the head. If there's no pillow around, you can use a jacket or any other piece of clothing material that can also serve as a pillow. You will want to protect from injury by removing any movable objects. If something is too difficult to move, just make sure the person is in a safe space, basically. And yeah, also you will want to avoid any overcrowding. Sometimes people tend to crowd incidents such as a seizure because they do not know what is happening and they want to be informed. But whenever that happens, remember you are calm and you can gently tell them just to allow for space for the seizure, basically, to have its way. Also, what is not listed here, maybe the next slide, you do not want to hold the person. You do not want to press them down either, because basically that can interfere with the person's breathing endeavors. And we don't want anything to hinder them in that regard. So you do not try to hold them. You do not try to press them down in an effort to cause the shakings or the convulsions to stop. Here's what you rather do. You turn the person to their side, and once you turn the person to their side, that will facilitate better breathing, basically. It will help to facilitate better breathing. Also, stay until full recovery. So make sure basically that the person have recovered, maybe not fully, but to a certain extent. If the person is a loved one, you will want to ask for their names after the after the seizure activity. If they respond accurately, you know that basically the person have recovered to a certain extent. If you do not know the person, you may want to ask what is the day of the week, and if that response is accurate, you also know that they have recovered to a certain extent. So why do I use the phrase to a certain extent? Is because some people after a seizure activity, they haven't recovered fully. Sometimes it can take hours. Sometimes it can take a few days. I know some people, it takes a few weeks basically for them to fully recover. So, but normally it's a few days or a few hours at most, a few hours or a few days at most. So sometimes they will report that they feel tired, but that is just part of the recovery process. But what you want to know is basic information like the name or the name of or the day basically of the week. And when that is accurate, you know that they have recovered to a certain extent. Also, you will check for any injury, and that is why it's important to remain until recovery, because you will want to report back. You will want to tell them basically if there was any injury that they developed during the seizure activity, or you will also want to describe the seizure activity in nature. So the person will then be able to revert to the doctor or to the neurologist, and they will explain what has happened to them. And there might be a need where doctor will have to change their medication or adjust their medication depending on the seizure activity and the nature thereof. Also, you want to preserve the person's dignity. It goes hand in hand with point number 7. So with ladies, we do not want to expose ladies, especially, or any person for that matter. So you don't remove the top entirely or bottom clothes entirely, because you are basically aware of their dignity and you want to preserve their dignity, basically. I think I already touched on that point. Let us talk about SUDEP. SUDEP is basically short for sudden unexpected death in epilepsy. It's basically a category of uncommon death within those diagnosed with epilepsy. It's where a healthy individual with epilepsy dies unobservedly in bed, basically. Sadly, 1 in every 1,000 persons with epilepsy die of SUDEP every year. And remember, like I said, with epilepsy, SUDEP can affect anyone at any given stage of their lives. Risk, basically, of SUDEP or causes of SUDEP, like I've said, is your seizures, your missed medication, being alone during seizures, alcohol and drugs. Remember also at night, your caregiver of your loved ones, basically, they are asleep. So that basically increases the chances of somebody dying while undergoing the seizure activity, because there's no one to respond to them. There's no one to do the first aid management on them, basically. So these are some of the causes. Like I've said, it's just your normal seizures that can cause a SUDEP. It can be missed medication. It can be you being alone during the seizure activity, or it can also be cause of alcohol or drug usage. Some of the preventions that you can implement is to take medication as prescribed, is to avoid alcohol and drugs, is to maintain healthy, is to sleep, basically, to maintain a healthy sleep exercise, to eat healthy, and also to try and manage stress. Also, families and caregivers are encouraged to learn CPR in the case of SUDEP, a SUDEP-related seizure. Let us talk about the laws and the acts. We know that the laws and acts do not only inform you about your rights, but it also helps to protect you, basically, in the case of unfair treatment because of your epilepsy, or unfair, basically, dismissal within the workplace as a result of your epilepsy. At Epilepsy South Africa, we deal with a lot of cases where people living with epilepsy, diagnosed with epilepsy, are often mistreated in the workplace because of the condition, or some even get dismissed because of the condition. So there are laws and there are acts that protect you and that informs you of your rights. So number one, you have the South African Constitution. You also have the Basic Conditions of Employment Act, number 10 of 2002. You have the Labor Relations Act, or number 66 of 1995. You also have the Code of Good Practice on the employment of people with disabilities in terms of the Employment Equity Act. And that is about it, amongst others. This is what we normally focus on. So you have the South African Constitution. The Constitution protects against unfair discrimination on the grounds of disability. We know that our Bill of Rights, as contained in the Constitution, Act 108 of 1996, in Section 9, subsection 3, stipulates that no one person may be unfairly discriminated against directly or indirectly on the grounds of his or her disability. You also have the Labor Relations Act and Basic Conditions of Employment Act, and these acts basically applies to all workers as to, it's basically guidelines as to what to do. Then you have the Code of Good Practice. The Department of Labor has accepted the Code of Good Practice in the year 2002 on key aspects of disability in the workplace, as it provides a workable platform to both the disabled worker and the employer. Then there's also reasonable accommodation. Reasonable accommodation means adapting to jobs, equipment, or schedules so that people with disabilities can work effectively. Very important to note, one person's perception about their disability needs and that of another, but the same disability may have different requirements. To just touch on this in a more practical manner, reasonable accommodation occurs once a person with disability or with a neurological condition has to be accommodated within the workspace. Maybe they cannot perform tasks the way they used to because of the severity of their condition. So now the employer and the employee comes to an agreement for them to have a change in their job role. Maybe they take up something more lighter. Maybe they begin to training. They become the trainer basically, or it can also pertain to equipment. Like I've said, people with photosensitivity epilepsy, those who are sensitive to flashing lights, sometimes that flashing light can emanate from a computer device or a computer software. So employers will want to change that. It can also be physical changes in the workspace, maybe like building an additional toilet or moving the person, relocating the person to a closer office that are close to the closer to the bathrooms. So those are more practical examples of reasonable accommodation. So who is involved in reasonable accommodation? The person first, the person with a disability or with a condition, and also the employer is also involved in reasonable accommodation. Let me just read through that. The disability is not, as it pertains to the person, the disability is not always an indication of what their needs may be. So once the person have epilepsy or once the person have any other condition or disability, that doesn't inform what reasonable change needs to take place within the workspace. Like I've said, that one person's perception about their disability needs and that of another with the same disability may have different requirements. Also, as it pertains to the employer, where reasonable and practical, technical experts were reasonable and practical, technical experts to develop practical and customized solutions. Sorry for that. And yeah, these are other examples, like I've mentioned. Adapting existing facilities to make them more accessible, adapting existing equipment or acquiring new equipment, including computer software, reorganizing workstations, changing training and assessment materials and systems, restructuring jobs so that non-essential functions are reassigned, and also adjusting working time and leave, providing specialized supervision, training, training and support in the workplace. I think that is about it. Any questions?
Thanks, Janome. That was a really fantastic overview of all of the aspects of epilepsy, giving some really clear practical guidelines on, how to identify and how to manage the seizures. We do have one or two questions that have popped up in the chat. I'm going to, Fiona has asked, what is the law now regarding driving if you are diagnosed with epilepsy?
Okay. Stan, the second question.
The second one is from Samantha, who raises a really good point that with regards to the new guidelines in transitioning patients from epilim to other anti-epileptics, there are some challenges with stockouts, making it difficult to change medications as no syrup or even tablet formulations are available at times. And so I think possibly, Samantha, you are in the state sector as well. This then causes challenges when you have to keep changing the medications, the formulations, due to the drug availability, and therefore it impacts on seizure control. And then one of the questions that we received prior to this was a question regarding compliance with medication and how it impacts on rehabilitation of our children and, well, particularly the children with epilepsy. So 3 questions there for you, Janome.
Can you just repeat the last 2 questions for me? Sorry.
So the last one is just asking about the challenges that we have, most likely from the state sector, in terms of making changes in terms of moving patients with epilepsy off Epilum and putting them onto other anti-epileptics, and having challenges where there are stock limitations at the prescribing hospitals. And so then you have to juggle back and forth with different anti-epileptics. So maybe if you can address the laws of driving first, and then just from Epilepsy South Africa's point of view, the challenges that we might face with the medication shortfalls in the state sector.
Okay. So to answer the first questions, or rather the first question, sorry, you must be seizure-free for at least 6 months. This is a new rule, basically. This often requires medical scanning. I know some scans are your CT scans or your EEG scans to confirm, basically, if your seizures are recurrent, if it's a lot, basically, then you need to be seizure-free for a minimum of 12 months. It was 2 years, but they've reduced it to 1 year. So if it's a single seizure, it needs to be 6 months, basically. You need to be seizure-free for 6 months. And once it is repeated seizures, actual epilepsy, then it's a minimum of 12 months, basically. And 12 months equates to 1 year. It used to be 2 years, but they've reduced it to 1 year. So you need to be seizure-free. And remember, seizure-free means that you do not have any seizure activity for 1 year in this specific context. And just in terms of the medication, basically, so we at Epilepsy South Africa, we use the psychosocial approach to epilepsy and not the medical approach. So what does the psychosocial approach basically means? It means that we are more concerned about the social impact that the epilepsy have on the person that is diagnosed with the condition. However, we do not debunk or we do not move or shy away from the medical approach. As a matter of fact, we basically refer people for medical assessment if we found that they have been having seizure activities. So we do believe in the medical approach, but we believe the medical approach basically stops with medication. It's where the person gets diagnosed with epilepsy, they consult the medical doctor or the neurologist, and the response from the medical professional will be to place them on medication, and that is it. And we at Epilepsy South Africa believe that there is never enough, that there is not enough. So what happens after the medication? What happens after the person leaves the hospital or leaves the clinic or leaves the day hospital? Because what the psychosocial approach helps us to understand, and what the psychosocial approach helps us to do, is to think of the person, whether the person has a job. If the person doesn't have a job, basically, it means that the person doesn't have an income. If they don't have an income, then they cannot buy food. If they cannot buy food, then they cannot basically drink medication, because you need basically medication. You need food basically to drink your medication. And whenever that reality is not at play, it becomes challenging. So we basically use the psychosocial approach. We look beyond the medical intervention. We look beyond the medical efforts, and we look how the condition has an impact on the person socially. What is the social surrounding? Some people, they live in houses where they get abused, for instance. GBV is rife. And as I've explained, that stress are one of the triggers of a seizure. So if the person newly diagnosed with epilepsy or diagnosed with epilepsy goes back into that specific household, they can have increased seizures. And actually, research has shown that people from lower income households are basically more prone to seizures compared to those of higher income households. Why am I saying this? Is just to point out that once it comes to the medical aspect, we normally refer them to doctors. We normally refer them to the medical professionals. We do not want to really touch on medication, basically. We want the doctors to deal with that, whereas we at Epilepsy South Africa deal more with the psychosocial aspect of epilepsy. But also, to answer to a certain extent, we do know that there is a shortage of some epileptic medication in South Africa, and it is quite challenging. We do know and we do recognize that reality. But however, we do encourage people to always adhere to the medical professional, to always adhere to the doctor and what they have to say, what they basically prescribe. Yeah, I know it's challenging, and it can be rather dangerous to switch in between medications, basically, but it's just a sad reality that is at play in South Africa.
Thanks so much, Janome. That really was such a well put together conclusion at the end, that we certainly don't want to just be looking at epilepsy from the medical perspective, that we want to be supporting the families and individuals with epilepsy from the biopsychosocial aspect as well. So looking at them holistically. And I think you have phrased that really, really well. So thank you very much. I know that we are quite over time. However, we do have Taryn Go, who is one of our executive members at SA ChilD, who herself has cerebral palsy and the absent type seizures. And so for those of you that can stay on for another couple of minutes, we just would love to have the lived experience as well from Taryn. So thank you very much, Janome. I know that you are not on your computer, but there's some really fantastic comments coming through. I think everyone has really enjoyed listening to your expertise and advocating so beautifully for epilepsy individuals and Epilepsy South Africa. So, Taryn, if you want to just share from your experience, just so that we can have that perspective as well.
Sure. Thank you so much, Jacqui, and thank you, Janome. That was really very comprehensive. I just want to add on the epilim issue. It's not just a South African issue. I have a friend in New Zealand who can't get it either, so it's not just us. So everything I'm going to say is literally my lived experience. I am not a medical professional, so please know that. I only realized I was having seizures when I was in my early 40s, which is when I was perimenopausal. And I put it together that something was very wrong and went and saw a wonderful neurologist who explained to me so beautifully how absent seizures worked. She used a computer scenario, and she said to me, you know, when we were younger, how computers used to freeze when you had too many windows open on the internet. And I was like, yeah. She said to me, that's what your brain does. And then it needs to shut down because you've got too many windows open and something with a virus running around in the background, and your computer needs to restart, and that's what your brain is doing. So it's shutting itself down so that all the electrical pulses that are going insane can just calm themselves down, and then your body starts again. And it takes about 10 to 20 seconds, and then you're fine. And I was like, cool, great. Except that I was having so many of them that it was not cool and it was not great. And eventually it was making me incredibly nauseous and incredibly, my body's reflex to anything is to vomit. So if I'm overexcited, I vomit. If I'm sad, I vomit. If I'm generally in a displaced place, I vomit. So there was many headaches and a lot of vomiting, and eventually I had an EEG after fighting with the neurologist about not having an MRI because I hate them, but I had one anyway. We discovered that I was having the seizures and they were quite frequent, and she put me on Epilim, which I was allergic to, which was not cool because she said to me, look out for a rash. And the rash appeared on my back, and I am single and was living on my own, so I didn't see the rash until my domestic worker came, and she was like, what's happening with your back? And I was like, I have no idea. So we changed medication, and that made me sick as well. So now I'm on Racetop. So it was a very Racetom, sorry. It was not an easy process to get medicated, and I just want parents and teachers and co-workers to understand that the getting medicated process is hard and lengthy, and I took so much time off work when we eventually added up all my leave days. From when I started having seizures to when I left my place of employment, I had taken 38 days sick leave in 19 months. As you can tell, I had a really great employer who let me just make up time at night time when I was feeling better. They were great, but it is a reality that it's a very real struggle. Things have settled now that I'm on the Racetop. I'm very, very good about taking it at the designated times in the morning and the evening. There's a 30-minute window, is the way the neurologist explained it to me. So I take it between 7 and 7:30 in the morning, and I take it between 8:30 and 9 at night. I make a concerted effort to get a good amount of sleep, and I had to say goodbye to wine, which was very, very sad. And when the neurologist told me I could have a glass of wine a week, I asked her how big the glass was, and then she just told me I couldn't have any, because you can have a glass that's an entire bottle of wine if you just buy the right glass. So we've just got to be careful with that sort of stuff. And then from a social aspect, I haven't told a lot of people that I have seizures because it's just another thing that makes things awkward. And when you already have CP, just adding something on top of it that you have to explain to people just makes it more complicated. So I just haven't told a lot of people. I told my employers when I was working for them, my family know, and my closest friends, but that's about it. Just, it's not something I want to get into socially, and thank goodness it's under control, so I don't have to worry about it happening in a hectically public space. I just want to look at my notes because I'm rushing through this because we ran a little late. Oh yes, being overstimulated. So my seizures The seizures I have are often caused by light, flashing lights, and bright white light. So I'm very much a yellow light girl in my home. And when I can feel the symptoms of a seizure coming, I will turn off all the lights around me except for lamps, and they're all yellow lamps. And I stay in a wheelchair. That way I'm not going to fall anywhere, because I've done that. When you're already unstable, it's not great if you have a seizure and you're standing, because you do go down. I also have to say recovery time for me is days. It's not a couple of hours. It's days of feeling disoriented and extremely tired. And after a seizure, I battle to recognize people. So I will like look at someone and know I know them, but I can't put them in the context of how I know them. And I forget things that I would normally know, like the name of my service dog, is just gone for a while. It's a good thing that he responds to the pitch of my voice and not necessarily to his name. So he will still come. But recovery time is longer. For me, that's my experience. I think being well medicated and understanding the importance of the combination of medication. So whenever I go and see a doctor, I tell them what I'm on, I tell them the milligrams of it, because so many medications can contradict each other, I think is the correct terminology. And so if your person, your child, your patient, your student has epilepsy, please bear in mind that medications don't always gel well with epilepsy meds, even antibiotics. I was put on antibiotics for a urinary tract infection, which caused seizures. So now we have changed the antibiotic I'm put on when I have urinary tract infections. So, because I had been completely seizure-free until the antibiotic and my racetam were taken together. So just something worth considering. Thank goodness I have a really good GP and she refers to the manual thing. I don't know what it's called, but she picks up a very big book and she looks up the right antibiotic. So just always tell your doctors that you are on epilepsy meds so that they can medicate you correctly. Is that cool? Jacqui, can I end there?
Yes, thank you so much, Taryn. I love how you share from the heart, and just to give that very real perspective as well. So we really do appreciate you sharing with everyone that's here tonight some of your experiences, and know that that's gonna just help others in their journey as well. And for the medics that are online, also just it's so important to hear from the individual that has the condition. So thank you for sharing with us tonight, Taryn. So we are quite over time. Thank you very much to everyone for staying. We've had a really fantastic session with Janome from Epilepsy South Africa, and Taryn just ending off the session with some beautiful lived experience as well. So thank you everyone for attending. Thank you to our wonderful speakers, and we look forward to seeing you next month for another SA Child webinar. Cheers then.